So early diagnosis is what people are going to focus on. Pat mentioned pain initiatives, dementia initiatives were mentioned, the Sequins initiative. So anybody here who works in acute hospital are going to get paid additional money for detecting dementia. So whether you like it or not, there's going to be a wall of diagnosis coming out of the acute hospital to you. That's what's going to happen, and maybe already have started. So, and the question is, have these people been referred on to a memory service? The expectation might be that you will refer them on, or you will deal with them. So that's one of the initiatives. General hospitals are a bad place to have dementia. So basically, again, that's part of this initiative here to tackle that. We've heard about Clive and the care homes, so I'm going to allude to that in the pathway discussion. And then they think they've dealt a bit with the antipsychotic medication, which I've talked on in this meeting before, and some of you have been at this meeting before. So we'll just wander through some of those aspects. When you look at the pathway, I mean, this might be a simplification, but it's from the National Dementia Strategy. So people turn up at some level, maybe some of them don't turn up at all, come to yourselves as general practitioners. Then there's usually a referral on to a memory service. Diagnosis is made. What is communicated to the patient at that stage, you need to know about, and I'll talk about that in a moment. There may or may not, you see, I diagnose people with MMSEs nearly at 26, 27 out of 30. So I'm not typical of what happens clearly in England and Wales. So I have a different perspective, but I've tried to broaden it to make this relevant, I hope. But care at that stage, voluntary sector, Alzheimer's Society, statutory care, and of course social services, as Clive said, works with the left hand and health works with the right. People then, the objective is to stay in the community for as long as possible. Some of what we'd have heard earlier on would imply that that's happening, because people are going into nursing homes later and later, and that could be a social class, finance-related issue. Certainly is the case in Northern Ireland. But that's also very innovative social care arrangements at home, which is not cheap. The dementia then progresses and people can be maintained still in the community, but often there's some urinary tract infection, a delirium, a fall, something like that. They may or may not have to go to hospital and they go back. If they don't, they go back into the loop, back home. So you manage them appropriately, keep them where they are. Or acute care, which is often a disaster. Your relatives or the carers will come in and tell you, oh, the hospital's just been such a disaster. So you want a timely discharge, which is what's not happening at the moment. And again, you can go back into the loop. And Clive talked about intermediate care. Or it fails totally and you go towards this situation, or community care fails, you go to this situation, or you go to palliative care. And that was alluded to this morning. So when you look at that pathway, you can see how, on a number of levels, you're going to have memory services constructed to try to deal with it. Where you're from, I don't know, it could be all over, but you probably have a local memory service. And it may not be all singing, all dancing. As I say, mine doesn't have all the facets. So the question might be, are there things that are not, the gaps to be filled? And I think that's it. If you've no memory service, well, that would be a worry. The national strategy said there should be one in every former Lloyds or TSB or HSBC or Royal Bank of Scotland, because a lot of these buildings are vacant now. So one in every town. And I think it's about the most cost-effective delivery of services, and as commissioning people, that's what you're going to want. So what do these things say? And again, sorry, these are text-heavy, but there's no other way to do it. So it's accessible to people. If you want to refer them in, are they seen in reasonable time? If there's a huge volume component, well then the people at my level and the managers need to look to see what level of service provision should we have to do this. I just heard in the last week, if you look at national numbers to train, this is an example of how this should happen. There are tons more old people in the United Kingdom. Why aren't there tons more geriatricians in training? That is about to happen. The numbers of national training numbers are to reduce in some specialties. They're increasing in geriatric medicine. The college states that geriatricians need to be in A&E. They need to be across the board, so there is happenings there. So people, specialists in old age, there will be more of them in time. And where it's an old age psychiatrist or a geriatrician, and a lot more geriatricians are taking an interest in memory because the acute hospital site is distant to the mental health trust site. So Exeter, for example, a couple of places I've been, and that's what they're doing. So accessibility, staff should be skilled and qualified, and also should be there should be professional development for the folks, so it doesn't stand still. Where the big professional development, and I'll be deliberately provocative down the line, and maybe in primary care, how much of this could you do yourselves? That's an interesting thought. And there should be multidisciplinary team working. Not telling you anything you don't know, but if I signed up to this accreditation program, they would come and monitor me based, are you delivering on these? But that's a good thing, because if we signed up for it and I'm not delivering on those, well then that's my armament to say, well look, we need to augment this slightly. So the dignity we've had Clive talk about, and basically we treat these people like people. We see them in the general hospital site, which has taken a lot of the stigma away. So I'm going to see a physician, and then the other problem is they all want to see the professor, because clearly I know everything and I've never wrong. Pat's a professor too, so she's the same. But basically, no, I'm not mad and I'm not going to the mental hospital. You must get that. I was at a meeting recently where 2 commissioners from East Anglia, and that was their comment to a couple of old age psychiatrists. We actually want to destigmatise, and this is one way these people don't need to go and go towards your institutions, and maybe more of them will come forward, because that's essentially what we want. And if we don't diagnose these people, we're just holding in store, and then there's going to be a huge lot of problems. Comprehensive assessment, that's important. Some of the tests are done first and foremost in primary care, and you know all of those. Are there any other things that they need? So I will pick up aortic stenosis, I will pick up atrial fibrillation. Those people get echocardiogram, they get referral to a cardiologist if they need it, they get managed and optimised because they're often early, but it will also help the course of their dementia. So just refer them on as other. That's where a physician is better than a psychiatrist, I suggest to you. Maybe in some respects, because in some parts of the world, geriatricians do a lot of the dementia work. And then there's this: as things deteriorate and decline, as they will do, you have to offer the appropriate levels of support, and of course support to the carers, really. So whatever setups you have, it's got to look at these things as well. Timely service to anti-dementia medication in accordance with individual needs. So if it's diagnosed early, NICE says treat early, and that's cost effective. You'll be familiar with the antipsychotic stuff. Again, if you don't feel expert enough to look at that, it could be an immediate problem, though. Well, you need recourse to somebody to advise you about that. That could be advice over the phone. Some places, I spoke to a couple of GP commissioners recently nearer London, and one of them was saying the hospital runs a total telephone consultation service a lot of the time during the week, where people can phone in, and there are consultant opinions available, and I think that's an excellent solution. It's very time efficient for everybody. So that would deal maybe with the antipsychotic issue. Everybody's got a care plan, and there's some level of follow-up. The difficulty is the volume of people. If I was talking to some colleagues in the audience, and all your patients are over 70 nearly, those of you that work on the coast, etc., that's a lot of people with dementia. I work in the place in Belfast. They mostly live in the inner city in Northern Ireland. It's the highest percentage of old people in Northern Ireland. It's going to be the highest percentage of people with dementia in Northern Ireland, and that is what happens. And the local managers don't understand the referral rates, but I say, would you just look at the population? Pat says it's right around it. It's not, it's here. This ageing thing has really happened. Medical practitioner, 2 other professions, they say. So that could be a mental health nurse. You'd be all familiar with those. They may work at a clinic, or they may work in the team in the community. If people are coming early, well, what do you do? Well, we do FDG PET scans. Now, you're light years away from getting an FDG PET scan for somebody with very mild cognitive impairment. But you need to have some way of teasing out, do these people have a problem or not? That's why a psychologist is recommended, neuropsychologist. And you might need a full-time one. And in fact, an occupational therapist can do much of that work, because if they assess activities of daily living and instrumental activities of daily living, they'll be able to say to you, look, I think this is a bit more of a problem than you've gauged at the clinic. That's also part of the multidisciplinary working that goes on. This is what, given that, as I say, this is written, and it's mostly old age psychiatrists who deal with this historically, it's desirable for access here. Speech and language therapists, there are various types of Alzheimer's disease, and you'll have seen this, the logopenic type, where the speech goes. Sometimes we're sent those people query stroke, but as a gradual onset, gradual decline, it's not a stroke. People with frontotemporal lobar degeneration, younger people, may need a speech therapist. Our speech therapists used to see people, then they say we're not funded now. Dietitian will know the problem with that is it's great and these people all lose weight, but Clive's alluded to what happens. Give them 40-sip, do, and do. It's a triple therapy diet. Hit in the bill in Northern Ireland at the minute, it's gone up to 19 million a year for nutritional supplements. You know, dietitians suggest, maybe as dietitians in the audience, everybody suggests, if, as Clive says, we feel these are not worth it, well, we don't prescribe them. And they cause diarrhea and they might cause I don't know what the story is, but I mean, we can't overrule, but there should be a genuine attempt to maintain nutrition and mobility with a physio, while people can understand rehabilitative principles. Social worker, a geriatrician, for if you're an old age psychiatrist, you will need physical or organic sort of advice. Neurologist, that would be for younger people mostly, or very atypical things. Old age psychiatrist, and those can be modified. So as I say, most people have a service and it's possible to tweak it, and that I think is what will happen.